In ER generally we don't take the big traumas like that. We leave them for the docs and the attendings and residents and all that stuff. So like level 1 trauma or even sometimes level 2 traumas we don't really see very often, at least in my department. That's not always true depending on where you work. Like if you're in rural medicine and you're the only PA at a clinic, then obviously you're going to try and see this patient. But I don't have a lot of familiarity with like chest tubes and cardiac massages and stuff. I did do a cardiovascular surgery rotation in my PA school, and when you do that, the reason you put like the 4 fingers flat to the sternal wall, as far as I know, is the heart is just a muscle. It is a strong muscle, but it's actually pretty easy to put your finger through the heart. So keeping your fingers like really flat and pushing against a flat surface, I would imagine, is the reason that they're not trying to like curl underneath and then potentially perforate a portion of the heart. With Dermabond and faces is not good, because what people don't realize is Dermabond heats up a ton when it activates, and little kids don't like the way that that feels. And if the cut is deep, then the glue goes deep into the wound and they're going to end up with a worse scar. It's more convenient for us to put on, sure, but if you're not convinced that the kid's going to sit still when it heats up, you could just make a worse scar. So 3 centimeters is kind of big for Dermabond, especially on the face. I would probably just put in a couple stitches personally, but that's because I've learned the hard way that the Dermabond doesn't work very well. Depends on the kid, depends on if it's gaping or not, but I would definitely, on the face, I would lean towards, and it looks like it was a little girl, so I would probably do some 6-0 monofilaments, try and make the scar as small as possible. You can do running sutures on the face if it's a non-mobile part. Doesn't take that long. So that's probably what I would do just from previous experience. So I guess this probably isn't like a huge case, but that's my 2 cents there. Common misconception that a DNR means like we're not going to do anything for you. He's coming in altered from a nursing facility or a SNF. He's probably most likely cause for altered mental status in elderly patients is UTIs. I would probably get a urine on him, do a chest x-ray, make sure he doesn't have a pneumonia. Second most common is pneumonia. Since he's altered, I probably am not going to get a good history from him. I would hope that I would get a report from the SNF, or at least some documentation, or a caretaker that was with him. Very unlikely to happen, so I'm going to do a pretty broad workup on him. CBC, CMP, like I said, urine, chest x-ray. I might run an EKG if he's tachycardic, which he may be if he's got an infection of some kind. I might, depending on how busy we are in the ER, I may just do a pan scan, like CT chest, abdomen, and pelvis, just to make sure I'm not missing anything. But I would probably have a discussion with my attending after I get a little bit more history. But he could be a potentially touchy patient, and I would want to do, depending on his vitals too, I need to consider a septic workup. If he's tachycardic, he has a fever, we might need to get blood cultures and fluid in him. I'm going to be honest, I have no idea what that is. That's a dentist referral. I would probably put like lidocaine on that. I might stab it with a needle, see if it's purulent. If it's an oral abscess, drain it, antibiotics, probably augmentin. Langdon is probably wrestling with his ghosts of past when he stole this guy's medication. And I'm wondering if he's going to take a conservative approach and try and just pop this thing, send him to dentistry with like topicals, or if he's going to give him stronger pain meds. I can only prescribe Schedule 2 pain meds in the ER. I can't send anybody home. I have to have my attending sign off on sending pain meds home. But patients in the past have tried to say they have severe dental pain and get narcotics out of me, which, yeah, I'm sure dental pain sucks. I've done dental blocks. I do viscous lidocaine, Tylenol, ibuprofen, and antibiotics when indicated, but you can just really do a lot more harm to patients if you send them home with narcotics for pain. I'll have to double check, but I think he meets, depends if he has a fever or not, but he's tachypnic, which means he's breathing fast. He's tachycardic, which means his heart's beating fast. We have a source for infection. And since he's needing a liver transplant, and I believe he's an alcoholic, he likely has diabetes type 2. That means he's immunocompromised. I'd be probably initiating a septic workup on him, making sure that he doesn't have a blood infection. He just doesn't look comfortable, and I'm not sure that that's fully secondary due to the tooth pain. Tooth pain specifically wouldn't cause shortness of breath and a fast heart rate. Maybe a fast heart rate secondary to the pain, but definitely not the fast breathing. So I'm a little worried about this guy right now. Okay, so he's afebrile, his urine's clean, he's tacky, he's about to go into VTAC, which is not good. If he's got a couple runs of VTAC, then we might be able to shock him out of it. That's why I was saying earlier, like potentially an EKG, you need to know if their confusion is secondary due to like hypoperfusion of the brain because of arrhythmias. I mean, his oxygen sat's pretty good, but I have a feeling that's about to disappear. And then his blood pressure is a little soft, so that means he's not doing great. You see the 100/79 there, that's fine. The little number to the right of that, the 86, is what we call mean arterial pressure. It's the top number divided by 2 plus the bottom number, and that gives you a number that basically we can quantify if they're perfusing their organs or not. Any map above 65 is good. So he's perfusing his organs right now, but I have a feeling that's about to change.
I don't know.
Liver failure. He's backing up his, God. I think that is a clinical finding of capitate medusa, where it's the prominent veins of the abdomen. And if his abdomen's hard and he's in liver failure, he probably has significant ascites, which is fluid buildup in the abdomen from different pressures, oncotic pressures from inside your vasculature versus outside your vasculature. And it all usually collects in third spaces, the most common being your abdomen. Can go into your lower extremities, but most commonly it's in your abdomen. Now I'm thinking he has SBP, which is small bowel peritonitis. So all that fluid is very dense in nutrients and minerals, and your bacteria, although they're generally inside the lumen of your intestines, can come out and then start to populate that area, and then you get an infection. So we're kind of still in the sepsis workup area. I'd probably put an ultrasound on his belly, see how much fluid's in there. We might do a paracentesis. I would check his platelets and INR and coags just to make sure that he has enough clotting factors so that if we do puncture something, he can clot off. And for the paracentesis, I would make sure we don't go through any of the veins that you see there, because those could bleed relatively profusely. And I would try and take off all the fluid I can on him. The research shows that if you only drain a little bit, it kind of comes back worse. And then I would send the fluid off for cultures to make sure that he doesn't have a white count, not a white count. I forget what the actual count is. PMNs, I believe, is the count. I think if they're over 300, it's indicative of SBP. And then he would get admitted to the hospital for sure. Regardless of what else happens, just looking at him, I don't want him to go home. Common for patients to get upsetty spaghetti at us because we ask the same questions like 19 different times. Especially if you're a walk-in patient, you first go to triage, they ask you what your chief complaint is, you tell them, you know, maybe a sentence or two. They literally write down like a phrase or a sentence like chest pain, shortness of breath, headache, whatever. I don't know what this lady's story is, but sounds like potentially abdominal pain or confusion or whatever based on just a couple questions we've asked. Then the nurse will interview them. They'll ask them all the same questions, kind of like a medium to detailed history. And then finally we get there, and if the nurse is like in the middle of her interview, then we get like, we're just going to ask the same questions. So I usually lead in depending on where the interview is at. I always say, hey, you know, my name's Josh. I'm the PA that's going to take care of you. I know you've told this story a bunch, but I haven't heard it yet. So can you tell me what brings you into the emergency department? And man, some people just really hate having to repeat themselves, and I get it. But at the same time, like we just can't transmit this information fast enough. And also, not everybody, before we talk with the patient, with you, is asking specific questions that we ask to get a clinical picture that may or may not lead us to doing more or less for you in the emergency department. So I get the frustration meeting whether to start albumin before or after the paracentesis. They're going to be there for a long while, and the albumin you give is not like a ton. So I would want to have all the fluid off of him first and then give the albumin, because then you know exactly how much you're supposed to give. Maybe some hospitals have different protocols. I think I'm more comfortable draining the fluid then giving the albumin, because the I forget what the secondary cause of draining all the fluid is. I think they can develop into like hypotensive, unstable vitals. I'll have to look it up. But that takes hours. So with someone as sick as him, potentially if he just needs the paracentesis and then it's decided that he's safe to go home, I'd rather do it the kind of slower, methodical way rather than just trying to get him out, especially because he has good rapport with everybody. Like, he's a well-known patient. He's been here before. He's used to the drill. I'd rather currently it doesn't seem like the ER is on fire, so we have time to treat him appropriately. But I'm still worried about his tack. So scaphoid fractures are pretty, I think, uncommon for falls. But if you have pain in what's called the anatomic snuff box, because I guess that's where people used to put their drugs or whatever right here, that's pretty clinically significant for a scaphoid fracture. And like she said, they usually don't show up on x-ray. The problem is, if it is broken, the blood supply specifically to that bone is very poor. And with a fracture, they don't heal well, and they can undergo what's called avascular necrosis, which means you don't have a blood supply to that area to heal. And then it'll die off, and you have diminished hand function, as well as honestly, I don't know what happens specifically after, if it gets fully necrotic. I don't know if there's infection risk or if it's just functional issues or nerve damage. I'll have to look that up. But it is something we always worry about. And anytime I have someone have a hand injury, I always palpate that area to try and make sure that they don't have any point tenderness there.